Welcome to Chapter 9 Behavior Therapy. This chapter may surprise you if you have heard behavior therapy described as cold, mechanical, or reductionist. As you'll see, contemporary behavior therapy is a rich, evidence driven, and humanistically applied tradition that has expanded dramatically since its origin in 1950s. It now includes mindfulness, acceptance and commitment, self-compassion, concepts that may feel more familiar from contemplative traditions than from a psychology laboratory. Before we begin, I want to set a frame how to approach this material. Behavior therapy is not one thing, it is a family of approaches united by a shared commitment to empiricism, measurable goals, and the careful application of learning principles. As we move through the chapter, I'll ask you to hold the question: what does it actually mean to help someone change their behavior? And what role does the relationship, the culture, and the client's own agency play in the process? Let's start with what behavior therapy does and where it shows up. This approach focuses directly on observable behavior, that current conditions that maintain it, and the use of learning experience to promote change. That's a different starting point from psychodynamic or humanistic approaches that we discussed in previous chapters. And these approaches often begin with the inner world, the past, or the felt quality of experience. However, behavior therapy has a slightly radical approach to changing behavior. Behavior therapy was born in 1950s, partly as a reaction against psychoanalysis, as you may know, many other theories, specifically against the emphasis on insight into unconsciousness dynamics as the mechanism of change. Behavior therapists argued that insight without behavioral changes is insufficient. What matters is what the client does differently in the world. The range of problems addressed is extensive. Behavioral therapy can be used in many disorders, including not limited to anxiety disorders, depression, PTSD, post traumatic stress disorder, various types of phobias, obsessive compulsive disorders, eating disorders, substance use, pain management, and even cardiovascular disease. Behavioral principles are also used in schools, sports psychology, rehabilitation, pediatrics, and organizational settings, far beyond the therapy office. There are some key figures, you may know those names: B.F. Skinner, who developed operant conditioning; Alfred Bandura, whose social cognitive theory brought modeling, self efficacy, and observational learning into the behavioral tradition; and Marshall Linehan, the recent person who developed dialectical behavior therapy, you may have heard of, one of the most clinically important innovations in the field over the last 40 years. As you read this chapter, notice how behavior therapy has evolved. There are three waves of behavior therapy, right? The third wave, that just like we mentioned, dialectical behavior therapy, acceptance and commitment therapy, DBT, ACT, and mindfulness based cognitive therapy, and also mindfulness based stress reduction, integrates mindfulness and acceptance in ways that would have been unrecognizable to the founders. The evolution is itself a reflection of the behavioral commitment to empirical revisions, as you will see in more detail. The history of behavior therapy is organized around four developmental phases, and understanding them help you see why the field looks the way it does today. Phase 1, as you see, classical conditioning. This is Pavlovian foundation. You may have heard of classical conditioning with the dog and bell example, right? The discovery that the neutral stimulus repeatedly paired with a stimulus that naturally elicits a response will eventually produce the response on its own. Pavlov's dog salivate to a bell, right? If you think of a dog and bell, now bell is neutral stimulus, right? And the dog has this natural inclination to have response to certain stimuli without conditioning, for example, food. So Pavlov's dog salivated to a bell because the bell has been paired with food. In clinical terms, a person who experienced a car accident may develop anxiety, responses to the smells of gasoline, the sound of traffic, even driving in a particular part of town. The neutral clue that has become a conditioned stimulus. And this principle is used as a therapy treatment in systematic desensitization, which we'll discuss in detail shortly, is built on this foundation. Operant conditioning, on the other hand, is Skinner's contribution. Behavior is shaped by its consequences. Reinforcement increases behavior likelihood. Punishment decreases the likelihood of behavior. And applied behavior analysis, some of you may work as ABA, used extensively in developing developmental these behavior principles in developmental disabilities, classroom management, behavioral medicine. That comes from different tradition, and that is as a part of this phase two. Right? There's another phase. It should be, and in here, third phase I would write is a social cognitive theory, right? That's Bandura's showed that we learn not just through direct reinforcement, but through observation. We watch others, form expectations, and regulate our own behavior. Self efficacy, the belief that we can successfully execute a behavior, turn out to be one of the strongest predictors of behavioral change. This phase brought the inner life, belief, expectations, self evaluations back into the behavioral model while keeping the empirical commitment. And that you notice that the phase, when you talk about, it's not always about learning behavior through either classical conditioning or by consequences, but also through vicarious learning. There's a term that it goes in detail, which is by observation. For example, a child start to do their bed because the parents do bed all the time. Never taught, never asked to, but just mimicking the modeling, right? That by observational learning. And you can teach complex behaviors through observational learning. And the phase four, you may hear about cognitive behavior therapy. This phase blended cognitive and behavioral methods, acknowledging the thoughts, beliefs, and statements interact with behavior in clinically meaningful ways. CBT has largely supplanted the term behavior therapy in many clinical contexts because it captures the full scope of the tradition. And now the third wave, DBT. Now, if you think of behavior therapy in terms of waves, so first wave, you see only behavior principles, right? You only see behavior principles. That is classical and operant conditioning. And in the second wave, so this is purely behavior principles. Second wave, you start noticing cognitive part. Cognitive part was added, right? The expectation, self-evaluation, like Bandura's idea. That's the second wave. And the third wave, it went beyond behavior and cognitive. Now the meaning of life, acceptance part, mindfulness, value, what make people continue to do things or engage in certain activities despite challenges. And that's where mindfulness and some of the principles in act and dialectical behavior theory you will see. That's the third wave, right? So in terms of phases, you saw classical conditioning, operant conditioning, social cognitive theory, and cognitive behavior therapy. In terms of waves, you see behavior alone, then it became CBT, cognitive part added, and the third wave, the values, right? Values, meaning, and also acceptance. The big part in here is mindfulness. So that came into play. Now, let's examine the central characteristic that defines behavior therapy across all its variations. And these are the features that unite the field. And like I mentioned earlier, first, behavior therapy relies on experientially derived principle and it grounded in learning theory. And the earlier I mentioned, like the first wave. So we're talking about the first wave, it's primarily grounded on learning principles. Techniques are not adopted because they seem intuitive or feel right. They were adopted because they have empirical support. And this commitment to evidence distinguishes behavior therapy from many other approaches. Think back in 1950s, all the therapists, all the psychologists were very much inclined to follow Sigmund Freud's idea. And it's mostly talking about insight. The humanistic approach you saw, psychology is challenged and there is not much tangible information that you can call study object. That's why behavior therapists start to look into what can we observe is behavior, what can we measure is behavior. Therefore, psychology should be about behavior. And that's what you hear. They're trying to find evidence that makes therapy, that makes study a scientific study. And the second, the focus is on current behavior, not historical antecedents. While behavior therapists may ask about the origin of a problem to understand the learning history, the primary target is what is happening now, right? And what conditions are maintaining the problem. A lot of the time, people think of um, behavior therapy is changing behavior. That is incorrect. What we change is the maintaining conditions. So we do not try to change behavior directly. We change what maintains the behavior. And most of the time, if you think from the ABC model, antecedent, behavior, consequence, behavior is, let's say, somebody uh, self medicate when they are stressed. Antecedent could be a lot of hours of work, right? And the consequence of drinking or using some kind of substance is feeling less stress. So, why this behavior is maintained? We know there is a lot of stress going on in life, and when they drink, the person feels less aware about their stress. So either A and B is maintaining the drinking behavior. And in behavior therapy, we don't try to ask people, or we don't ask people to stop drinking. We try to change either the antecedent, it goes, there's more detail, but try to change the setting, either the cues. Remember, either the bar or the availability, accessibility, that's the A. And C is how it feels after you drink, after somebody self medicate. And you try to change the consequence, not the behavior directly. And that's what it meant, like conditioning. What main conditions are maintaining the problem. And this is clinically important. We do not need to revolve childhood trauma in order to change a current anxiety responses, right? If you think of behavior therapy approach, it's very present oriented. It tried not to look into a lot of the history because there's a lot of criticism, right? If you think of about the past too much, how do you know somebody is drinking now because of childhood trauma? It's very hard to connect all the relationship between the childhood trauma to current because it doesn't make sense if you compare it to everybody who had childhood trauma. Do they all also engage in drinking behavior? Not necessarily true. So why people drink now has to do with what's happening now. So try to, it got a little messy there. Uh, so we try to find out what is maintaining that behavior. So coming back, yeah. So we try to find out how the current behavior is maintained, right? And third is behavior is defined broadly. It includes overt actions, as you can observe, as well as internal process like thoughts, feelings, and physiological responses. They are all considered behavior. This means behavior therapy is not as narrow as the popular caricature suggests. It's not only behavior. There's a physiological part, thought part, feeling part, so on. And fourth, behavior treatment is individually tailored. There is no one size fit all behavior program. The classic question behavioral therapists ask is what treatment by whom is most effective for this individual with this specific problem under these particular circumstances. Very specific. This is a deeply individualized clinical question. And fifth, change can occur without insight. This is one of the most important and most contested claims in all of psychotherapy. Behavior therapists argue that you can help a client reduce a phobia, build social skills, or manage depression without them ever understanding why they developed these difficulties. Now, if you think of, in simple, insight into underlying dynamics is not essential to producing behavior change, right? Now, do you agree? Think of something you changed in your own behavior. Did you need insight to change it? Sometimes we always talk about making sense of the problems, but sometimes the change could occur without that insight. And now, this is not my stand, this is what behavior therapy stands. So that's what I'm trying to highlight here. In behavior therapy, Goal setting is not a preliminary set step before the real work begins. It is the work, right? A hallmark of this approach is the identification of specific, concrete, measurable, and collaboratively defined goals as the very outset of therapy. And this matters for several reasons. Why do we need to set a clear goal? Right? First, it makes therapy accountable. If goals are vague, like I want to be happier or I want to improve my relationship, there is no way to know whether therapy is working. Behavior therapy insists on translating broad wishes into specific target behaviors. So, target behavior is very important. We try to find out what specific behavior are we focusing, and that should be clear, concrete, and that's what I like to use, SMART acronym: specific, measurable, achievable, relevant, and timely. That's what SMART goal means, right? We try to pinpoint what is it that we're trying to change. Second, collaboratively, goal setting reflects a fundamental respect for client autonomy. In behavior therapy, the client controls what behavior is to be changed, and the therapist controls how it is changed. This division of responsibility is ethically significant. The therapist does not decide what the client should want. The therapist brings expertise in methods, and the client brings expertise in their own life. In a way, it sounds like similar to what you heard in client centered, person centered therapy, existential therapy. The therapists are just the facilitator, right? Right? With the knowledge, the expertise, and the tools, the client themselves has to choose how the behavior is shifted from maladaptive to adaptive behavior. Now, again, going back to the ABC model, right? The ABC model: antecedent, behavior, and consequence. So sometimes people have trouble spelling that. Antecedent, that means something that happens beforehand, and behavior, and uh, ABC. C is consequence. Right? Is a functional assessment framework that guides this process. The therapist conducts a behavioral assessment interview to map out what happens just before the problem, before behavior occurred, right? Remember the example? What happened before you start drinking? What exactly does the behavior look like? What do you do? The behavior itself, what follows it, what is the consequence of that behavior. Now, it's not a long term. If you think of somebody self medicating, the long term consequence could be addiction, could be some kind of health issues, but that's not what we're talking about. We're talking about the immediate consequence of the behavior, because that behavior either reinforces, that means the consequence of the behavior is likely to increase the chance of behavior repeating. Somebody is stressed, they consume alcohol, the consequence is feeling relaxed, feeling less tense, is the consequence. And that becomes a reinforcer to the behavior. That means the person is likely to consume alcohol when they're stressed again because they remember how it felt. Or let's say somebody in the same scenario, somebody is stressed and they consume alcohol, and the consequence is nausea, right? Let's say they cannot tolerate the smell or the taste of alcohol. Now, that consequence leads to punish. That's what we call punishment, because the likelihood of that behavior of drinking goes down. It is punished. That means the behavior is not going to repeat, more than likely. So when somebody is stressed, if they consume alcohol and they feel nausea, next time when they're stressed, they are less likely to engage in that behavior. So you see that ABC model helps to analyze the relationship between behavior, consequence, antecedent behavior, and consequence. So the therapist conducts a behavioral assessment interview to map out what happens just before the problem, right? What happened, and then identify the behavior, and then look at whether it is reinforcing or punishing as a result of the behavior. Think of another example here. Helen, a 6-year-old Chinese American child, referred to nail biting. Her nail biting increases when she was asked to read aloud in classroom. That's the setting, right? Again, antecedent is being in the classroom, asking to read out loud. Now, what happens as soon as she hears that? The behavior itself, which is her nail biting, increases, right? So the behavior itself is biting nail approximately 25 times per school day. So it's a very specific behavior. You made it measurable, okay? That's measurable problem. The consequence of biting is, as you can tell, reduce anxiety in the moment. So when somebody asks you to read out loud, the child read out loud, the behavior is starting to bite their nail. The consequence is immediately feeling less anxiety, which reinforces the behavior. Now, this is the consequence, less anxiety, right? Next time when she's asked to read again, she remember how it felt when they bite the nail. So this becomes a reinforcer of that behavior. Understanding the ABC pattern allows the therapist to develop a behavioral substitution plan, replacing nail biting with rubbing her thumb across her nail tip when become anxious, or supported by positive reinforcement from her mothers, right? You're trying to find something that works, giving a stuffy, giving a ball instead of biting nails. So you try to find a substitution that will serve the purpose, not always, because now that's a simple, if you think of the problem of nail biting, might be simple, but in the long run, that might be problematic. So you might be careful when you try to substitute. Sometimes you try to extinct, right? Let's say somebody has the, now that's another way to change or eliminate the behavior. You don't want to replace something else because that becomes now, person might become dependent on that behavior. Now think of the girl Helen, she is biting nail, and we try to tell her, like, we paint something on her nail that edible, but it tastes very bitter, right? That's a sort of aversive therapy approach, but also we can also train them to resist, sit through the discomfort, and allowing that should happen in the therapy session first, and when they become anxious, not biting nail, but just like letting it happen and not allowing to get that consequence of feeling relief lead to extinction. So there's behavior therapy is a lot. When I used to teach a class called 3351 behavioral modification, we talk a lot about behavior therapy entire semester. It's a very wonderful classroom. We talked, how behavior therapy is broadly used in many settings and breaking down all these ideas into small pieces. Just to keep it simple in terms of this introduction part, I hope that makes sense how ABC model allows you to understand behavior and try to find a solution. There's more, but at least you're now introduced to these ideas. This is the ABC model in action, right? Assessing the contingencies, finding out what works, and maybe we can also plan contingency plans. We're trying to design target intervention. So the many things can be done through the understanding ABC model. Through behavior therapy, although behavior therapy is technique focused, it is not technique only. The therapeutic relationship is understood as a necessary, though not sufficient condition, unlike persons under therapy, to change behavior. This phrasing is important, necessary but not sufficient. Remember, the relationship alone wouldn't produce change. Specific behavioral techniques are required, but poor relationship will undermine even the best techniques. The client's experience in behavior therapy is active and collaborative. Clients are not passive recipients of interventions. They are partnered, they are partners in assessment, goal setting, planning, and evaluation. They are expected to do homework. They are asked to self monitor. They are taught skills that they then practice between sessions. And that's what we call homework assignment. Yeah, they are given homework between the sessions. So today we had a session, and between 7 days, the client is asked to complete those tasks. That's like they're expected to do homework. They're also asked to self monitor their taught skills. And the goal is for the client to become their own therapist. In a way, changing, not necessarily to become a therapist as like a licensed person, but more self-guided to change behavior, to internalize the tools and apply them independently in daily life. And that's why you hear a lot about CBT more being very effective because it's not only limited to 50 minutes, it goes beyond therapy session. Behavior therapists are active, directive, and psychoeducational. They explain the rationale for each techniques, model skills, and provide feedback and trace progress. This transparency is itself a form of respect. Clients are kept informed about what is being done and why. Because if you think of, let's say somebody is afraid of elevator and you're trying to work with behavior therapy, they might use exposure therapy. And when you do that, we'll talk about that in a minute, the client and therapist would go to the elevator. So you might not hear this a lot in other therapy. They're often set in the therapy room, sit down and talk, but behavior therapy would go to elevator and walk with you and try to model it's not life endangering. So there's a lot more different in compared to other approaches, right? Contrast to psychodynamic approaches when the therapist's relative opacity and neutrality serve a therapeutic relationship or function. In behavior therapy, the therapist is explicitly a consultant, teacher, and to some extent a problem solver. The role difference has real implications for how therapy feels to client. Now think of case example of Lynn, 55 years old woman working with a doctor using multimodal therapy. That's in if you look at the example, that shows active collaboration built very well. The therapists assess uh, across different models, right? You try to identify what is affecting you and also identify specific targets from intervention. And if you look at some of these activities, you will understand um, the therapists are very involved in clients' life in this therapy process. Now, we move into the specific techniques of behavior therapy, some of them, not a lot, beginning with two foundational methods: progressive muscle relaxation and systematic desensitization. Progressive muscle relaxation, PMR, is exactly what it sounds like. The client systematically tenses and releases major muscle groups, moving through the body from extremities to the core, learning to recognize the difference between tension and relax. PMR has applied to chronic pain, panic disorder, hypertension, insomnia, and sometimes surgical preparation. And also, you can find some detailed protocol. Sometimes not all of them are reliable, if you search online, but I encourage you to try them out. Knowing a technique conceptually and knowing it experientially are two different aspects. For example, as simple as this, you can take your hands and close the fist as tightly as you can for 5 seconds. As you do, focus on the tension that is built on your palm. And after 5 seconds, you let go and you notice. Now pay attention to the release that you felt after you let go of that tension. When you do this, now I'm just did the fist, but if you do from face, tightening your face and muscle and relaxing, you do part by part the entire body. You're trying to activate the parasympathetic nervous system to reduce that tension. And this principle is applied in teaching individuals to become used to, right? If you have panic attack, you often focused on increasing heartbeat, increasing breathing, rather than shift to relaxing. It's counterintuitive to do so, but it also helps you to in terms of how it works. The mechanism part is you're activating parasympathetic nervous system, which is calming effect. That is a peripheral nervous system from overactivated sympathetic nervous system where we are in fight, flight, freeze mode. Now, systemic desensitization was developed by Joseph Wolf and is based on classical conditioning principles. The logic behind it is anxiety is a conditioned response. If you can pair the feared stimulus with a relaxed state repeatedly, just like the dog and bell, right? Across a hierarchy of progressively more threatening situations. And when I say hierarchy, that means you try to find the anxiety response to certain situation. Let's say somebody is anxious of flying. So, what would be the least scary thing to think about when you are afraid of flying? Probably talking or hearing or seeing somebody in a plane. Maybe the least, right? Nerve wracking versus you yourself being in a plane. So there's a hierarchy of anxiety. And you also use subjective unit of distress, SUD, when you try to ask to build this hierarchy. You ask them, when you think about talking or seeing somebody in a plane, how anxious do you get in a scale of 1 to 100? And that's the subjective unit of distress. They might tell you, when I think about somebody in the plane, I feel 25. My anxiety level is 25. Now you build on that 25, 30, 45, so on, and being yourself in plane is extremely, extremely nerve wracking. So the purpose of systematic desensitization is you teach how to relax by either using progressive muscle relaxation, right? The procedure has three components. I want you to know. Teach the client deep relaxation. First, you do that. Whether it's progressive muscle relaxation, diaphragmatic breathing, sometimes body scanning. It's one of them, right? Deep relaxation. Then construct the fear of hierarchy, right? A fear hierarchy from least to the most anxiety provoking situations. And then have the client imagine each situation while maintaining relaxation. So every time you make a list, you take from the bottom. Okay, let's look at a picture or imagine somebody in a plane, right? When you tell the client, they imagine seeing somebody in a plane and you ask them, what is your SUD right now? It went up by 25 to 28. Let's say they say that, then you tell them, pause that imagination and then ask them to, okay, let's do the deep relaxation. And you go on and item by item. What you're doing is trying to uncondition or recondition how you respond or how you feel about taking a plane. Eventually, client can remain calm or relaxed even while imagining the most fear scenario, right? If you think of here's a client example, Aisha, who's a 22-year-old student who has severe test anxiety, and that's not a diagnosis. So I want you to know, test anxiety is very prevalent, but it is not a clinical diagnosis. But people could be very anxious about taking tests, right? She cannot sit down to an exam without experiencing near panic. Working with, uh, this systematic desensitization, her therapist first teaches her progressive muscle relaxation. Again, you start from your head to bottom, learn to relax, tense, relax, tense, relax. Takes about 15 to 20 minutes. And then together they construct a fear of hierarchy, like we did here. At the bottom, you receive a syllabus that mentions a future exam. Let's say that is the item. At the top, sitting in the exam room with the paper being distributed. That's the most scary part for her. Overall, multiple sessions, Aisha pairs relaxation with each imagine on the hierarchy until even the top item are no longer trigger a significant anxiety response. And then she moved to in vivo exposure, actually sitting in the exam environment while practicing relaxation. Now that's the next level. Now I want you to know it doesn't happen over one session, right? The other part is anxiety is going to be there. And we're not trying to eliminate. I want to be careful. We're trying to reduce the unmanageable extreme anxiety. Okay. This session is a little longer than I thought because behavior therapy has a lot to teach you, and that's what I'm trying to cover as much as possible. Exposure therapy in its various forms is among the most well supported behavior interventions for anxiety related conditions. The core principle is straightforward: anxiety is maintained by avoidance. You talk about anxiety disorder, there is avoidance in everyone. When we avoid feared situation, we never learn that the feared outcome either will not occur or is manageable. Because when you avoid, you have a presentation, you skip the class, you would never know that you could have done it and it's not as bad as you imagined, right? Avoidance is negatively reinforcing what you've been avoiding or the person is avoiding. It reduces anxiety in the moment, which makes it more likely to happen. Remember ABC model. So presentation is coming, you skip the class, you immediately felt good. So the feeling good immediately right after skipping the class does seem like a good idea, but in the long run, the consequence of missing the grade, having to do redo, or constantly avoiding those situations will not change the anxiety you have. So we try to uh, identify, right? When you avoid, it reduces anxiety in the moment, which makes it more likely to happen again, which strengthens the avoidance pattern. Exposure breaks this cycle. In vivo exposure, in vivo exposure examines exposing the client to actual anxiety evoking situations, not imagined. That's why it's called in vivo. Um, yeah, not imagined. And they're trying to face the real one. For a client with social anxiety, this might mean approaching a stranger to ask a question, giving a presentation, or attending a social event. The exposure is graduated, beginning with less threatening situations and move toward more challenging ones, always within the client's range of tolerability. It's never forced, right? Just think of the hierarchy. You always take from the item, the bottom, the least anxiety provoking to the most. So it's gradually client builds the autonomy, the self efficacy is there, right? You start feeling like I can do this part. And the floating is not very popular for many individuals because floating is more intensive. It's a prolonged and direct exposure to the most feared stimulus without the opportunity to avoid or escape. This is done in controlled clinical setting and is not appropriate for all clients. It works because the sustained exposure allows the anxiety response to extinguish, but it requires careful preparation and clinical judgment. That's what you see. And in vivo or prolonged exposure, there's an example. I will try to post it in the module. There's a person who has fear of snake, came in with a lot of anxiety about snake, even they didn't have to deal directly. After 4 to 5 hours later, they were able to carry the snake on their neck. And I sometimes joke in my class, how many of you are willing to do exposure therapy so you can leave without the fear for that given object or situation? Not everybody's cup of tea. Okay, and the other one that you might have heard is eye movement desensitization and reprocessing, which is another exposure-based therapy that integrates imagining floating, cognitive restructuring, and bilateral stimulation to process traumatic memories. EMDR has substantial research support for PTSD, but also sometimes there is criticism about this approach. So the three prolonged protocol addresses past adverse experience that underlie current disturbances, present cues that triggers distress, and the future situation where the client needs to function effectively. Now, I want you to keep in mind there is researchers continue to debate exactly how EMDR works, whether the bilateral stimulation is the active ingredient or whether it is the exposure and cognitive processing elements. The debate does not undermine the clinical evidence, but it is an honest intellectual questioning worth holding. So I want you to know that EMDR, that is eye movement desensitization and reprocessing. It works, but there are some criticism you might want to be mindful of. Social skill training and self-management progress are two behavioral interventions with wide real-world applications, including in criminal mental health settings. Social skill training addresses a deficit that appears in many clinical presentations: the inability to interact effectively with others, to ask for what one needs, to refuse requests, to express disagreement, to sustain a conversation, to manage conflict. This isn't about personality, it's a learned skill set, right? Training typically involves modeling, that is, demonstrating the target behavior, and behavior rehearsal, practicing the behavior in session, and reinforcement plus corrective feedback. If you think of the case of Stan from the student manual or from the videos that you watch, you see that very well. Stan wants to approach a professor during office hours, but is held back by self doubt and fear. The behavioral therapy uses behavior rehearsal, role playing the conversation in session with coaching. The question of how to handle if Stan does not do his homework, which he admitted that that it's worth point. Also itself clinically interesting, the behavior answer is neither to punish nor to shame, but to analyze what antecedents and consequence made the homework difficult to complete and redesign the plan, right? So another part is self-management program. You may have heard of that. Self-management program teaches client to become agent of their own change. Self-management. If you read the text, you will see some examples there. The process includes selecting realistic goals, translating those goals into specific target behaviors, creating an action plan, self monitoring, keeping records of behavior, and evaluating outcomes. And that's where self efficacy comes handy. The belief that one can execute the behavior is central to whether self management succeeds. And also, if you look at the student manual, if you have a copy, self-management design exercise that I highly recommend completing genuinely. Pick a behavior you actually want to change, identify your target behavior, design a monitoring system, identify your reinforcer, and evaluate it weekly. Not a hypothetical, as a real behavior experience experiment of yourself. I'll keep it light because this also might come back in cognitive behavior therapy. Now we will talk about behavioral therapy briefly. There's the third wave of behavior therapy. Yeah. So just to just to introduce the ideas, and we might talk a little detail in chapter, I believe, 12. It's cognitive behavior therapy. I think it's either 12 or, yeah, it will come back. Now, if you look at this, there's a third wave that's cognitive behavior added with this mindfulness aspect, right? Mindfulness is defined as being aware of the emerging experience and paying close attention on purpose in the present moment with curiosity and withholding judgments. Mindfulness based practice assists clients in becoming observers of their own inner experience rather than being fused with it, right? A client who struggles with anxiety thoughts learns to notice, right? Anxious thoughts learn to notice, I am having the thought that I will fail. Rather than saying I am failing, you're trying to make them aware of their thought. I'm having the thought that I will fail. Rather than fusing, that's the term you see in in ACT, cognitive fusion, right? You're fusing. I'm gonna write that again. You're fusing with the experience. So we try to separate by identifying the thought. And the distinction between that a thought and being fused with a thought is one of the most clinically powerful ideas in the third wave of behavior therapy. It has deep resonance with contemplative traditions, including Buddhist mindfulness practice, which is explicitly acknowledged in dialectic behavior therapy, mindfulness based stress reduction, and acceptance and commitment therapy. And the core themes organize the five core themes organize the third wave of cognitive behavior therapy. Psychological health, acceptable outcomes in therapy, acceptance, mindfulness, and creating a life worth living. The last phase, creating a life worth living, comes directly from dialectic behavior therapy, and it captures something essential. Behavior therapy, at its best, is not just symptom reduction, it is the construction of a meaningful, valued, engaged life. And I want you to pause and reflect. What would a life worth living mean to you? What behaviors, relationship, and commitment would be present? This is not merely a question or philosophical question. In behavioral terms, it points toward values clarification and behavioral activation. And we'll talk about some of these in detail in the next chapter. Now, dialectic behavior therapy was developed by Marshall Linehan, especially for individuals with borderline personality disorder, a population characterized by intense emotional dysregulation, impulsivity, and chronic suicidality, right? Standard CBT was not effective for this population, and Linehan recognized that emphasizing change without adequate acceptance felt invalidating and drove clients out of therapy. DBT's central dialect is this: the client is doing the best they can, and they need to do better. Both are true simultaneously. This synthesis of acceptance and change in the theoretical core of DBT. DBT teaches skills in four modules: mindfulness, the foundational part, and the second is interpersonal effectiveness, right? You try to ask for what you need, saying no, maintaining relationship, emotion regulation, understanding and managing emotions, and distress tolerance, surviving crisis without making them worse. DBT has strong evidence from research. It also reduced suicidal behaviors, psychiatric hospitalization, substance use, and self-harm. Linhan drew explicitly from Zen and contemplative practice in developing DBT. She translates mindfulness, which is the original text involved, years of meditation practice into behaviorally specific teachable skills. And it's a remarkable synthesis. And the other one is ACT, acceptance and commitment therapy. Again, we'll talk a little bit more, but the point is taking a different approach to the same core problems. ACT argues that the psychological suffering arises largely from experiential avoidance, the attempt to control, suppress, and eliminate unwanted inner experience. The harder we fight our thoughts and feelings, the more tangled we become. ACT invites client to accept their internal experience and diffuse from unhelpful thoughts, clarify their values, and commit to actions aligned with those values. The goals are not to feel better, it is to live better according to what genuinely matters to you, right? In my dissertation thesis for masters, I did study what makes mindfulness work, and I was doing research on ACT, and I found those who are psychologically flexible tend to be more mindful and they tend to suffer less from psychological distress. That people, those who are psychologically inflexible, they tend to be less mindful. And those less mindful individuals are psychologically inflexible. That means they are more rigid, they're not open to changes, they're not open to differences, and they tend to have more psychological distress. So that's my experience, doing research and also teaching mindfulness for a long time as a Buddhist monk. And we'll talk a little bit more on mindfulness in CBT. Finally, strength from a diversity perspective. There's a lot to share, but from a multicultural perspective, behavior therapy has significant strengths. It is structured, transparent, and skill focused, qualities that make clients from non Western collectivist or historically marginalized communities find accessible. The emphasis on concrete problem solving and brief interventions align with how many people understand self help seeking behavior, health seeking, right? Behavior therapy also attends to environmental, social, and political conditions that contribute to clients' problems, which is relevant in communities where stresses are systemic, not merely psychological. And there are some shortcomings. Therapists who use behavior techniques narrowly without attending to cultural context may teach skills that doesn't fit the client's relational world. Teaching assertiveness to a client whose culture value deference and relational harmony requires cultural adaptation. A newly assertive behavior practice in session may create conflict at home if the culture context not even taken into consideration. And some contribution, behavior therapy offers a specific, evaluable, and approachable, adaptable set of skills. Outcomes are measured, progress is tracked, the approach has been studied across diverse population, the literature continues to expand, the integration of mindfulness, acceptance, and self-compassion into the behavior tradition has opened conversations between behavior science and contemporary traditions that are genuinely enriching. And there's some limitations too, right? Therapy has been BT has been criticized for focusing on so narrowly on measurable behaviors that is missing the meaning making, existential, and relational dimensions of human suffering. Some clients find the directive, psychoeducational style impersonal. And as you see in the text, the author, the success of therapy is in proportion to the ability to control environmental variables, which is often quite limited in real life, right? So before I leave, how would you integrate behavior approach with other frameworks that you've been learning? Where do you see the greatest synergy and where do you see some tension? Now, if you look at the reflection, you will find some good place to talk about these approaches. I'll see you in the next video.